Hello, sir. Hello, sir.
Good evening.
Good
I
evening,
am
sir.
Dr. Chezhiyan, nephrologist from Coimbatore. Okay, last time we had an interesting topic on hyponatremia. This time it is again another interesting topic, very common in your day-to-day practice. Whatever the specialty you choose, you cannot escape without seeing an urine report, which will invariably will show whether there is proteinuria or not. So it is something which you should understand thoroughly, irrespective of your specialty, more so if you are going to become a physician or a nephrologist. Now, literally speaking, the term proteinuria, it means there is protein in the urine. But normally you got a small, very small amount of protein in the urine. So definition purpose, we call it as excessive urinary protein excretion. That means which is something more than what is normally expected in the urine. Normally you cannot detect by your routine test, which we will be seeing little later, the minimal amount of protein which is present in the urine. So you pick up protein by doing a test, that means there is proteinuria. So that means it is more than the usual amount. Normally we eliminate or we excrete around 150 milligram of protein in a day. So the presence of proteinuria is very important for two reasons. One, it is a sign of renal disease. Because if you take kidneys, we got very few points to pick up a renal disease, that is a kidney problem. Clinical features are very minimal. Most of the clinical features related to nephrology like dysuria, painful micturition and other things, mostly they will go with urologist. Those who are coming with kidney disease, probably they may come to you with some leg swelling or pedal edema. So otherwise there is not much signs or symptom and signs for the kidney disease. Most of the time kidney diseases are diagnosed by lab investigations. Of that, one is urinary analysis. It includes not only proteinuria but also a microscopy and a blood investigation, that is blood urea and creatinine, which shows whether the kidneys are excreting the waste normally. So the presence of protein in the urine, it is a cardinal sign of renal disease. So it cannot be ignored. But sometimes it can be a non-pathological one, which we will be seeing in few slides. Second one is presence of proteinuria is very important, and it is the one which we will be following up to know about the progression of a renal disease, and it also indicates the individual is going to have a more cardiovascular disease and mortality. By assessing the proteinuria, you can have a guess that this individual is prone to develop a cardiovascular disease. Again, that also we will see subsequently. Just see a few classical clinical setting where you may pick up proteinuria. This is a 3-year-old boy presenting with a puffy face, edema legs. The mother notices the child is very heavy when she tried to lift the child. You examine, the blood pressure is normal. Urine shows 4+ proteinuria, no RBCs. You do the blood urea creatinine, it is normal. You evaluate the child further. You find the child has got hypoalbuminemia and has got a hypercholesterolemia. So it is a classical nephrotic syndrome, a disease which is diagnosed by just doing a urine analysis. Next is another classical situation where a 45-year-old female, a diabetic for type 2 diabetic for 7 years, very irregular in treatment and follow-up, admitted for a non-healing ulcer in the leg, diabetic foot. So you find her BP is slightly elevated. She has got bilateral pedal edema. You do the urine analysis, it shows 3+ proteinuria. Urea creatinine slightly elevated. Normally urea should be 40. Here it is 52. Creatinine, which should be 1, it is 1.4 here. So there is a slight elevation of urea creatinine, indicating the patient already developing mild renal failure also. And further evaluation showed she also had diabetic retinopathy and cardiac system also was involved. So this is a classical case of diabetic nephropathy. If this lady was on regular follow-up and if the urine analysis was done much earlier, you could have picked up the disease at a very early stage before she could have developed a renal failure. So this is a little quite a late stage of diabetic nephropathy where the patient has developed a significant damage. Third setting is a 18-year-old female with history of fever 4 days, very high grade, treated outside, not improved, so was admitted. So found to have a normal blood pressure, urea creatinine is normal. Urine analysis showed a 2+ proteinuria, few RBCs, 6 to 8, not very significant. Further evaluation of the patient showed she was viral strongly positive. It's a case of enteric fever, treated with appropriate antibiotic. She became afebrile, but she had 2+ proteinuria. There is no reason a patient with enteric fever or typhoid fever should have a proteinuria. So this proteinuria was analyzed again, repeated after 2 weeks. It was found to have no proteinuria. So this is a condition where you find what you call as functional proteinuria, where you may have a proteinuria due to a non-renal problem. So because of high grade fever is one where you can have proteinuria. So just because proteinuria, don't think that this is a case of UTI or something like that. You don't divert your attention, but a proteinuria should be rechecked to see that it disappears later in the life. So a 2+ proteinuria can be due to just a non-pathological one, what you call as functional proteinuria. A similar type of proteinuria you can see with patient after doing a strenuous exercise, you can have proteinuria. Patient with congestive cardiac failure because of the back pressure. When you have congestive cardiac failure, more pressure in the IVC, more pressure in the renal vein. Because of the back pressure, you will have proteinuria, but their kidney will be normal. You treat the cardiac failure aggressively, reduce the volume overload, then you repeat the urine analysis, you find the proteinuria disappears. So there are so many conditions in which you will have proteinuria, which will disappear once the primary problem is corrected. This patient is not having a renal disease, so we call it this as functional proteinuria, not a renal proteinuria. Another example, another case, it really happened to me some few years back, almost 15-20 years back. So a 20-year-old female, a school teacher, came for some minor surgery in the face, some cyst excision. So went to a plastic surgeon, so no complaint, normal BP. So pre-op routine investigation, they will do one blood sugar, basic urine analysis and one blood count. That is the usual test which is done for any minor procedure. The urine analysis showed 2+ proteinuria, no RBCs, where blood pressure was normal. The surgeon didn't give much importance for that, but she underwent the surgery. But anyway, it is not a contraindication for the surgery. After surgery, the patient received few days of antibiotic with a non-steroidal anti-inflammatory drug. She developed post-operatively when she came for follow-up, she noticed her face is puffy and she had pedal edema. So initially it was thought as a NSAID induced. Many people are very sensitive to non-steroidal anti-inflammatory drugs. So they develop edema, you stop the drug, they become all right. So it was still persistent. So subsequently she was referred to me, repeated the urine analysis that showed now the protein analysis was 4+, no RBCs, serum albumin was low, serum cholesterol is high. It's a case of nephrotic syndrome. Of course, when she presented to the plastic surgeon some 1 week earlier, there were not much symptoms, maybe minimal edema, which she never realized. But the 2+ proteinuria was not given much importance or was not evaluated at that time. But anyway, it's not a contraindication for surgery. Then subsequently, I did biopsy for it. It came as minimal change disease. It's less common in adult, but it came as minimal change disease. One course of steroid, she recovered, never had a relapse. And of course, now after that, she is married with 2 kids now. So on yearly follow-up, she is coming to me since she is little worried because she had a proteinuria. So this is a case of nephrotic syndrome. It just came just as a 2+ proteinuria without any other symptoms at that time. So a protein in the urine, otherwise a proteinuria, at one end it may be just a temporary, unimportant or a non-progressive renal abnormality. On the other end, it may be the first, probably the only evidence of a serious renal disease. Some of the patients just with proteinuria, you evaluate, you find they have more and more disease like renal failure and so on and so forth. So any proteinuria, always evaluate carefully. Before we go into the clinical aspects, Just we will brush up our knowledge on biochemistry and physiology. So normally the urine contains a very small amount of protein, usually less than 100 milligram. Maximum it will be 150 milligram in a day. The main protein in the urine is what you call as stem horsewall protein, which is a glycoprotein secreted by the distal tubules. So it will account for almost 40 to 50 to 60% of the protein in the urine. So after 150, it will be somewhere around 70 milligram will be the stem horsewall protein. Very, very small amount, that is less than 30 milligram in a day, gets of albumin gets excreted in the urine in a day. It's a very, very small amount. So, but again, why this number is important, again, we will see when we find out, when we talk about microalbuminuria. A small amount of immunoglobulin A, roughly around 6 milligram, is excreted every day. This immunoglobulin A comes from the lower urinary tract. It comes from the pelvic calcium system, ureter, and urinary bladder, and so on. It's a immunoglobulin is a secretory immunoglobulin present on surface of various tissues. Of course, urinary tract also secretes a very small amount of immunoglobulin, only 6 milligram in a day. Other component will be mucopolysaccharides, again something secreted in the tract. Then you will find a small protein molecules like lysozyme, beta-2 microglobulin, light chain, retinol binding globulin, and insulin, and so on and so on. So many substances are normally filtered at the level of glomerulus. Yes, all these small micromolecule can escape glomerular filter, but in the tubule, generally they are almost completely reabsorbed. So very small amount can escape into the urine. They will constitute the remaining part of the protein in the urine. So the normally you have very small amount of protein, maximum 150 milligram is excreted in a day. Roughly we are taking as an individual produce 1.5 liter of urine in a day. That is a usual rough calculation what we have. Major protein is going to be the stem horsewall protein, which is secreted by the distal tubules. So normally, if you take the glomerulus, normally we know kidney receives almost 1/4 of the cardiac output. Normally, our cardiac output in a day is around 5 liters in a day. Of that, 1,250 ml of blood comes to the kidney, and they have to pass through the glomerulus. So they receive a fairly very large volume of blood. That means your plasma contains significant amount of protein. Roughly, you have got 6 to 7 grams of protein per deciliter. So in a day, if you take the glomerulus, it is presented with almost 50 to 60 grams of 60 kilograms of protein in a day. Of that, it remarkably conserves almost all the protein. Only a very small amount is allowed to excrete. I mean, allows to go through the glomerular basement membrane filter into the tubules. But again, the tubules also act very actively, especially the proximal convoluted tubule. They start reabsorbing most of the protein or catabolizing the most of the protein. So finally, leaving a very small amount of protein in the loop of Henle. In the distal tubules, you will find Tamars protein is secreted, then collecting it also secretes. Then when they come to the pelvic calcium system, some IgA is contributed, and so on. So practically speaking, a very, very, very small amount of protein only escapes this glomerulus as well as the tubule. So the normal handling of protein by the kidney is by glomerular filtration and tubular reabsorption. Out of 60-70 kilograms of protein which comes into the glomerulus, around 1,800 milligram of protein can escape into the glomerular filtrate. So what are the factors which is going to decide whether the protein is going to leak into the glomerulus? Normally, the protein, very, very small amount, only 1,800 milligram of protein, they reach the glomerulus. The factors which are going to decide about the glomerular filtration, one will be the molecular size. Very large size protein cannot pass through the glomerular basement membrane, glomerular filter. Classical example will be your immunoglobulins, especially IgM, too big molecule, IgG and other things. They cannot pass through the glomerulus. So that is, size is the one which decides. Second is the charge. If you take the size of the albumin size is not as big as the immunoglobulins. It can pass through the glomerular filtration barrier, but the main factor which prevents albumin to get into the filtrate is the charges. The albumin is negatively charged outside. Similarly, you find the endothelial cells as well as epithelial cells, they are also negatively charged. So they repel and they see to that the albumin does not escape into the urine. So charge of the particle, especially the negative charge on the surface, especially for the albumin, is the another one which decides whether something is going to be filtered at the level of glomerulus. Then third thing is what we call as glomerular hemodynamics. That means what we mean by that is glomerular pressure. So normally the glomerulus has got a pressure through which is essential for the filtration. Of course, the filtration is opposed by the oncotic pressure in the pressure by the protein in the glomerulus, which is again opposed by the hydrostatic pressure in the Bowman's capsule. Of course, these are the factors finally which will decide how much is going to be filtered. When the glomerular pressure is very high due to some reason, you will find there is more and more protein can leak. So the three factors which decides about the leakage of protein at the level of glomerulus is going to be the molecular size, negative charge on the particle, on the albumin especially, then the glomerular pressure or the glomerular hemodynamics. Once they come into the tubule starts reabsorbing. Due to some pathology in the glomerulus, if you find more protein is escaping into the tubule will act more. They will not allow all the protein to go up. So normally 1800 milligram is filtered every day. Tubule reabsorb almost 1750 and so on. But if in case, suppose the glomerulus allow more protein to leak, say 5 grams, 6 grams and so on, even more protein is going to escape into the tubule, they will start reabsorbing more and more protein. And again, they see to that very small amount escape into the urine. So these two structures are very important in handling the protein by the kidney. So this is the structure of the glomerulus. You find the afferent and efferent arterioles. And of course, this is the glomerular endothelial cells. That is a red down. Then the yellow one are the epithelial cells. So that is the visceral epithelium. Of course, parietal epithelium is here. This is the Bowman's capsule. This is the glomerular capillary. Of course, mesangial cells are given in the blood. So this is what we call it as the filtration barrier. So you find the endothelial. This is the side where the blood is present. So endothelial cells, you have got lot of fenestra or pores. So through which the particles or the protein can escape. Then you have got glomerular basement membrane. This also has got a pores. Then you have got slit diaphragm on the epithelial cells. That is otherwise called as podocytes. So they have got slit diaphragm. So finally, depending on the, as I said earlier, smaller the particle can escape. If the negative charge is lost in the endothelium or the epithelium due to some reason, classically happens in minimal change disease, where the main problem is where there is effacement of food process, the negative charge is lost, so that the albumin is allowed to leak very freely into the Bowman space. Then, as I said earlier, the pressure in the glomerulus, the hemodynamics. So these three factors will decide whether the protein is going to escape into the urine or not. If the protein escape into the urine, they are not, again, suppose the albumin escape into the urine, they are not allowed to go out freely. So as they pass through the proximal tubule, these tubular cells, they start acting and they start absorbing the albumin, pushing back into the circulation, either as a whole or sometimes very often they are fragmented into small particles and again they are given to the bloodstream. So protein, if it escapes into the urine, that means it has to pass through the glomerular filtration barrier should be lost and tubular function also should be lost. Or it can be any one of the two. Sometimes it can happen just with the glomerulus or sometimes only with the tubule. Both components need not be affected. So what is the clinical presentation of this patient? Do they have any complaint? A patient with a massive proteinuria will have edema because of hypoalbuminemia. When they lose a lot of protein in the urine, invariably they have hypoalbuminemia. So the massive proteinuria, they will have edema. Probably one complaint they come and say will be the foamy urine. They are passing the foamy urine. They pass urine in the closet. So after pouring water, if it is a Western closet, after flushing it, they find still that foamy nature is still present in the urine. So this is what we call it as foamy urine. Some people call it as even frothy urine. So this is the probably one finding which the patient they notice and they come and tell you. So I find my urine is not normal. That is a foamy urine. So if you give the container, probably when they pick up in the container massive proteinuria, that time from the container itself we can say this patient probably having proteinuria. Of course, just by if they say foamy urine, you cannot straight away say it is proteinuria. You have to do a confirmatory test. So you have got two types of tests for analyzing the urine in the protein. Analyzing the protein in the urine. One is qualitative test. That is whether the protein is present or not. That is what we call as qualitative test. Quantitative test is how much of protein is present in the urine. Of course, most of the qualitative tests are converted to semi-quantitative by standardization. Certain standardization you do, you can guess whether that protein leakage is very minimal or it is mild, moderate, or even severe. So that is what we call the semi-quantitative. So all qualitative tests now they are basically we use it as semi-quantitative. Basically, we have got three types of tests. One is heat coagulation test. Second is sulfosalicylic acid test. Third is the dipstick test. Of course, when we were interns, say almost 35 years back, when we were doing our internship or even post-graduation, probably the most common thing what we were using is a heat coagulation test. Those days in Kilpatrick Medical College, all biochemistry lab will be closed by 2 o'clock. So almost all the ward will have bedside lab. So the duty of the house surgeon will be to check them whether there is any proteinuria. Of course, we used to do urine microscopy. We used to do RBC count, WBC count. Sometimes blood smear also we will be seeing. LP we will do and do a gram stain. So most of the tests are very essential. Will be done in the even at the night time in the bedside lab. Almost all the ward will have a bedside lab. Especially more so in the labor ward. Labor ward, most of those days, most of the cases are not booked. So they will come for third delivery, seventh delivery, fifth delivery, not bothered. They were not booked. Suddenly they come with a labor pain. So you have to do the urine analysis. One of the duty of the house surgeon is not only check the BP and clinical finding, you have to collect the urine, do the test. Probably the even sulfosalic acid, if it is not available, straight away you can go for heat coagulation test in the side room. So to find out whether they have got any proteinuria. So if it is proteinuria, yes, they are segregated into a separate category and they are managed as usual. But sulfosalic acid also was available at that time. That is sometimes the chemical may not be available. Heat coagulation is a little more simpler. Of course, nowadays it is totally replaced with what you call as a dip test, dipstick test. So of that you can do only for albumin. Sticks are available. You have got sticks for albumin and sugar. But more often what we call it as what we use it as a multi-sticks. Multi-sticks picks up blood, RBCs, sugar, ketones, nitrite, which will show whether there is any infection or not, anything like that. So most of the so many tests can be done in a just by a single strip. That is the one what we commonly use. That is called multi-sticks test. So you confirm, you find with the multi-stick test somebody is having proteinuria. It may not be enough if you suspect a serious problem. Then you have to go for a quantitative measures, where probably the golden standard will be to collect the urine for 24 hours. That is what we call as 24 hours urinary protein excretion. Collect the sample for 24 hours and then you subject and analyze how much of protein is being leaked. And if you find it is say 600, 700 milligram in a day, it's a significant proteinuria. More than 1 gram is more pathological. If it is more than 3.5 grams in a day, it becomes a nephrotic range of proteinuria. We have seen up to even 20, 30 grams in a day. So we have seen. So patient with severe nephrotic syndrome, maybe primary or secondary glomerular disease, you have seen massive proteinuria. So that is about the 24 hours proteinuria excretion. So again, I will elaborate in subsequent slides. So this is a simplest, probably one of the earliest tests used for the heat coagulation test. You collect the urine in the test tube, heat the upper column. So upper half of the urine you heat, then you find that it becomes, if there is no protein, it's clear. If there is a protein, it becomes cloudy. Cloudy, it becomes white. And sometimes the phosphate in the urine also will present as cloudy urine. So in that, so we have to add 1 or 2 drops of glacial acetic acid, 10% acetic acid to that sample. If it is phosphate, it will dissolve. If it does not dissolve, it is protein. Then after that, we can have standardization, whether it is slightly turbid, whether it is white or it is very thick, it is curdy white. So with that, we can say it is 1+, 2+, and so on, so on. This is a very simple test, very useful test in a bedside practice. Next is sulfosalic acid, where you take urine in the test tube, add equal amount of say 3 ml of urine you take, 3 ml of sulfosalic acid you add. You add 3 parts of the thing. So you have to add a sulfur. With that, again, if you want to make it as a semi-quantitative, you have to have some calculation. So one part with 3 parts, if you calculate, if you add 1 part of urine with 3 parts of sulfur, you will get similar pictures. Again, which can be divided into trace 1 plus, 2 plus, 3 plus, and if it is very turbid, we can even call it as 4 plus. So this is the sulfur salicylic acid test. So now, of course, with the dipstick test, it has been given up. So dipstick test, you can pick up glucose, you can pick up protein, bilirubin can be found, urobilinogen, nitrate, which may indicate infection, ketones can be seen, blood can be seen, hemoglobin, presence of leukocyte can be seen. So specific gravity, so many things can be done in a one strip. This is the protein strip. Again, here also with the color change, we can make it as trace 1 plus, 2 plus, 3 plus, and 4 plus. So this is very useful test. You have to use it. You have to dip the urine for at least 60 seconds. Some labs, some sticks comes with 30-second reading. So it mainly detects albumin. That is one problem with the dipstick test. It may not pick up a smaller molecules like your light chains. So you may miss. Somebody comes with typical frothy urine, but you find no proteinuria by doing dipstick test. You do a collection, 24 hours collection, you will find a significant proteinuria is there. Finally, if you work up, it may turn out to be a multiple myeloma. So multiple myeloma always may be missed if you just go by a dipstick test. If you clinically suspect, yes, next is you must ask for the other test, more definitive test. So this is one problem with the dipstick test. It will mainly detect albumin. That is the one which we pick up in most of the clinical situation. We will miss light chain. So you may have false positive result even the urine is very much concentrated. The patient has not taken much water. If they pass concentrated urine, a 1 plus proteinuria may look as 2 plus, a trace proteinuria may look as 1 plus, and so on. Similarly, a very alkaline urine, normally urine is acidic, sometimes due to some infection or so. If there is alkaline urine, again it may show us as a positive result. Similarly, if you drink too much of water, and again a very dilute urine will show a false negative result, or it may show less. For 3 plus may be shown as 1 plus and so on. Very acidic urine also will have a false negative result. So you have to be a little careful, and you should be a little careful in the history. Again, as I said earlier, before you ask for a urine for a dipstick test, make sure that patient does not do exercise. Like some people, they go for early morning walking and then they go and give the urine for the test. So you should tell them on the day of investigation, they have to avoid walking or do extraneous exercise. Don't go to gym at least on 1 day previous. So if they don't have febrile illness, they should not give. Contamination can happen with the menstrual bleeding. So if they have menstruation, they should not give the urine for sample. Severe cardiac failure and other thing, better avoid urine analysis at that particular moment. So that you have to be very careful. Then if it is present, then you can have idea, some amount of idea how much of protein is being lost. Okay, you have picked up somebody is having a significant proteinuria, say 2 plus or 3 plus. Then what you should do is you have to quantify how much of protein they really lose. From dipstick, you can have some idea whether it is mild or severe, but the 24 hours is the probably you can say it as a golden standard. Here, what the patient do is you have to give a container with the chemicals, which with the preservative. The patient morning he starts the collection, say 7 o'clock or 8 o'clock. He notes the time. He goes to the toilet, void his urine. Say if he starts at 8 o'clock, he collects all the samples till next day morning 8 o'clock. So 24 hours they have to collect and give the sample for the analysis. You measure how much of protein is present in that urine. It will tell you what is the 24 hours protein. The main problem is it is little difficult. Patient has to put a leave. As I said earlier, if they cannot do strenuous exercise and other things, it will increase the proteinuria. So they have to do it on a holiday. And they have to visit the hospital. First day they come and see the doctor, get the can. Next day they go and collect, and then third day they come back. If they are come from a faraway place, it is very difficult practically. So this is replaced with a very useful test, what we call it as urine protein creatinine ratio. Here what we do is, as I said earlier, I said if the urine is concentrated, you find you have got more protein. If it is dilute, you have got less protein. But when you have the concentrated protein urine, naturally the creatine concentration also will be very high. Similarly, if you have a dilute urine, protein is diluted, creatine also diluted. So somebody thought, why can't we use it as a ratio so that we can have an idea whether how much of protein is being lost? And it was a very, very standardized test. where you measure both in a same unit. Like for example, milligram per deciliter. You take a sample, you find out how many milligram of protein is present in that sample per deciliter for 100 ml of urine. And similarly, you measure how much of creatinine is present in milligram in 100 ml of urine. So same unit, you use milligram per deciliter. And you take a ratio. This ratio will give you the 24 hours of urine, 24 hours of urinary protein in grams. What I mean is, if you have 40 milligram of urine protein per deciliter and 40 milligram of creatinine per milligram, 40 milligram of creatinine per deciliter. So 40 is to 40, so it is 1. 40 bar 40 is 1. So that means roughly this individual is excreting 1 gram of protein in a day. Suppose the urinary protein is say 40 and urinary creatinine is say 400 milligram. So 40 into 400, so that means 0.1. So they excrete only 0.1 gram of protein, otherwise 100 milligram of protein in 24 hours, that is normal. Suppose if they pass 400 milligrams of protein per deciliter in that spot urine, and you find urinary creatinine is 40 milligram per deciliter, that means their protein creatinine ratio is 10. So they have got a severe nephrotic proteinuria. Nephrotic also, it is much more severe. Nephrotic 3.5 itself, we call it as nephrotic. So by doing just a one spot urine test, where you do urine protein assay, you measure in milligram per deciliter, do a creatinine assay in milligram per deciliter, take a ratio that gives what we call as urine protein creatinine ratio, which has almost replaced 24 hours protein in our clinical practice. Most of the lab we stick on to protein creatinine. Similarly, we got one thing called as albumin creatinine ratio, which we use mainly for diabetic, for screening to detect the diabetic in the early stages. That is what does urine albumin creatinine ratio, where you take albumin versus serum, urine creatinine. Again, the same formula will apply. Now, proteinuria, if you want to classify, somebody has got proteinuria. So how will you classify this proteinuria? Otherwise, pathophysiology of proteinuria. The proteinuria can be from glomerulus. As I said earlier, if the glomerular filter is damaged, you get a fairly severe or a massive proteinuria, what we call it as glomerular proteinuria. Usually due to a glomerular disease, again you have got a lot of glomerular disease. You have got minimal change disease, membranous nephropathy, IgA nephropathy, and so on. They are all primary glomerular disease, FSGS, and so on. Then you have got a big category of secondary glomerular disease. Probably the commonest one is the diabetic nephropathy. You got SLE. SLE again damaging the glomerulus, and again a big list of infection related, drug related, heavy metal related damage to the glomerulus, which can be even malignancy related damage to the glomerulus, which we call it as a secondary glomerular disease. So generally the glomerular disease produces a fairly significant or a massive proteinuria. As I said earlier, before you jump into the diagnosis of proteinuria, rule out a functional proteinuria as it happens with CCF, exercise, and so on. Next is tubular proteinuria. Sometimes your glomerulus is normal, your filter is intact, it doesn't allow the protein. Only as I said earlier, that only 1,800 milligram of protein escapes your glomerular filter. A very small amount of albumin, less than 30 milligram, very small amount of albumin escapes into the glomerulus. But as they pass through the tubules reabsorb most of the protein. But if you have a tubular damage, tubular disease, tubular interstitial nephritis, and so on, when you have a tubular disease, you will find the tubules are not able to reabsorb the protein, which is normally filtered at the level of glomerulus. This is what we call as tubular proteinuria. Classically, they will have more of light chains and small molecules, beta-2 microglobulin, and so on. Generally, it is less than 1 gram per day. It's not nephrotic proteinuria cannot happen with just tubular disorder. Nephrotic proteinuria, if it is there, it's not pure tubular disorder, because it can be maximum, because as I said earlier, glomerulus allows only 1,800 milligrams. So of that, even with the maximum damage, still half of the protein can be reabsorbed. So it is generally less than 1 gram per day. Of course, by doing a urine protein electrophoresis, probably you can pick up what type of protein is escaped by the tubule. Third category is what you call as overflow proteinuria. Here the kidney is not damaged. Kidney is okay. Glomerulus is fine. Tubules are also fine. But you find due to some reason, more amount of protein gets filtered at the level of glomerulus. That is what we call as spilling. That is typically happen with a very small molecular weight protein like light chains. Both lambda and kappa, especially typically with multiple myeloma. Even patient after rhabdomyolysis or crush injury, myoglobinuria, intravascular hemolysis, hemoglobin. So these are all relatively smaller molecular weight substances which can escape into the through the into the glomerular filtrate, even though the glomerulus is normal. So tubules is normal. Tubule try to reabsorb more, but still, when the spilling is very much, it cannot reabsorb much. So the proteinuria escapes. Similarly, in the acute phase of pancreatitis, the amylase level is very high. Normally, amylase is less than 100. In pancreatitis, it goes up to about 1,000, 2,000, 3,000, and so on. So that amylase also gets filtered at the level of glomerulus easily. So it can escape as a proteinuria. When the primary problem is corrected, it will disappear. So here the kidneys need not be damaged, but still you find a very significant proteinuria. As I said earlier, remember, multiple myeloma can be missed by doing just dipstick test. If you suspect, do a PCR, urine protein creatinine ratio, which will be good. Then you get another common or fairly frequent clinical setting. You get what you call as inflammatory proteinuria. This typically happens with the lower urinary tract infection, where you find there is more immunoglobulin A is secreted by the pelvic calcium system as well as the urinary bladder. So the urine will have proteinuria 2+, 3+ with a lot of pustules, pyuria. You treat with antibiotic. Once the infection settles, you find the proteinuria also disappear. So this is what we call it as an inflammatory proteinuria. So you may have problem in the level of tubule, but both are all right, but still more amount of smaller molecular protein is filtered. That is called overflow proteinuria, lower urinary tract problem. So coming to the clinical classification, a proteinuria it is except certain situation what we earlier described. We said about certain benign condition, which can be a primary renal disease or it can be a secondary to a systemic disease. So whenever you have proteinuria, if you think it is a benign one, wait for 2 weeks, 3 weeks, repeat the urine analysis with certain precautions, and you find if it disappears, just keep them on follow, forget about it. But if it is not going, then probably you have to investigate them further. Always you have to check a BP whenever somebody comes with proteinuria. Simple, always you can do it at our clinical practice. Urine microscopy, generally when you send for urine, microscopy is included. If microscopy is showing RBCs or RBC cast, so it indicates something serious with the glomerulus, some problem with the glomerulus. Do urea creatinine to assess the renal function. If they are abnormal, probably one ultrasound abdomen may be required. And in a glomerular disease where you want to go further, like doing a renal biopsy and so on, probably before that, better you do a 24 hours urinary protein, or at least do a protein creatinine ratio. So there is one thing what we call as microalbumin. This is commonly we use it in diabetic patients, but also in other patients like hypertension also being used. Normally, as I said earlier, in a 24 hours collection, you find less than 30 milligram of albumin. Now we are going to talk only about albumin. So far you have talked about protein. Now I am going to talk only about the albumin. So you find a 24 hours urinary collection will show only a less than 30 milligram of albumin in the urine. More than 30 milligram of albumin, generally it will be showing having a more than 500 milligram of in a day. So that will show, that will be picked up by the normal dipstick test as 1+, and if it is more, even 2+ and so on. So a normal dipstick test picks up a urinary concentration of more than 30. So that is more than 300 milligram in 24 hours will be picked up by urinary dipstick test. That is what we call as macroalbuminuria. Normally less than 20, no albuminuria. Between there is a category called microalbuminuria. Especially in diabetic, we always screen, especially on their yearly follow-up till if they get a renal disease. So we will be checking it and pick up the renal damage little early. That is what we call as microalbuminuria, where it is between 30 to 300 milligram in 24 hours. It can be detected by a dipstick test, separate dipstick test, what we call as microal test, or more commonly we use what we call as albumin creatinine ratio, like what we did for protein creatinine. So by doing albumin creatinine ratio, we will know how much of microalbumin is being excreted by the kidney. So the presence of microalbumin, it is the early onset of diabetic nephropathy. In a diabetic, when they develop microalbumin, it is called as a diabetic nephropathy, probably the first stage of the diabetic nephropathy. Then it progresses to macroalbuminuria, then it becomes renal failure, then becomes end-stage renal failure, and so on. So microalbuminuria is an early indicator. This is very important because at this stage, if you treat vigorously, especially by controlling the diabetic as well as hypertension, if it is there, even whether hypertension is present or not, they are given ACE inhibitor and ARB, which will control the microalbuminuria. Probably it can even reverse the disease. So when you pick up the disease at this stage, you can prevent a catastrophe later. The presence of microalbuminuria not only indicate the predilection for a renal disease, it also indicates these individuals will be having other associated complication of diabetic like ischemic heart disease, peripheral vascular disease, they may have retinopathy, and so on, so on. So other organ also you have to be looked into whenever somebody has got microalbuminuria. It is a marker for a multi-system problem in a patient with diabetes. Of course, it is the one which is the forerunner for the classical diabetic nephropathy. Now, by picking up proteinuria, what is important? I said earlier. So, it is a marker for kidney damage. It indicates the disease is progressing. Somebody's proteinuria keep on increasing, the kidney damage is being worsened. But also, you find the cardiovascular risk also is increased, especially in a diabetic. They have found the moment they develop microalbuminuria, their risk of developing a cardiovascular risk, developing a MI or a cardiovascular sudden myocardial infarction or severe ischemic disease, almost it is increased by 3-fold when they develop even microalbuminuria. When they develop overt proteinuria, you find almost the risk is increased by 10-fold. So the presence of proteinuria indicates something grossly abnormal, not only for the kidney, even for the cardiovascular risk factor. Similarly, if you take, this is a Indian International Society of Nephrology guidelines, where they say when somebody is having kidney disease, whether you treat, that is the green is the general practitioner can treat, and green is the one where you don't need treatment. Then the general practitioners treat at stage 1, this light yellow, then dark yellow, they can still treat. But after that, once they become red, they have to refer to a nephrologist because these people are likely to get bad. So this is the way they divide the chronic kidney disease into stage 1, 2, 3, 4, depending on the glomerular filtration rate. If it is more than 90, it is taken as stage 1. 60 to 90 is stage 2. 45 to 60 is stage 3A. 30 to 45 is 3B. Then 15 to 30 is stage 4. And stage 5 is the end stage renal failure. So this is how they decide. And then they say stage 1, 2, you manage. Like there is, I mean, stage 1, 2, no treatment. Stage 3 is still no problem. General practitioner can manage. Here you have to manage with probably you have some concern. At least you contact or call a nephrologist and take a help. Then after that, if it has become 3, 4, you have to refer. This is the usual protocol. So all stages need not be referred to nephrology because otherwise they will have a very big workload. So this is the usual protocol. But if they have proteinuria, once they develop microalbuminuria, then even one stage earlier itself, they say better send it to nephrologist. If they have macroalbuminuria, it is even that. So macroalbuminuria, they cannot treat. A general practitioner cannot treat even if they don't have a renal failure. So because of presence of proteinuria itself, they are supposed to refer, and the risk has become very much increased. So what I mean to say is, even though you may not have renal failure, if you have a massive proteinuria, that indicates your kidneys are very much damaged. You are likely to land up finally in dialysis in a very short time. So a proteinuria is something which you cannot monitor, especially if the proteinuria is getting worsened. They need more vigorous treatment and further analysis. So just 2 slides on the management of the proteinuria. Always treat the cause. So you have to find out what is the cause for the proteinuria. So if it is a secondary, like as I said, diabetic developing problem, it may turn out to be a SLE having a problem, or it may be due to some native drug treatment, or it may be due to our own drugs like gold, penicillamine. Some of the drugs, the drug itself can produce proteinuria. So if it is something you find a cause, treat the cause. So to control the diabetic and treat the SLE, withdraw the offending agent. So that is always the basic treatment for that thing. If the massive proteinuria is there, they always have edema. So probably they will require diuretic. That's a separate topic. Then, do you have any specific drugs to reduce proteinuria in individual? That is, we use ACE inhibitor and ARB. Collectively, I call them as a single group because by mechanism, it's almost same. It is they act by renin-angiotensin system inhibition. So this is a drug is specifically used for them. Any type of proteinuria, whether they have hypertension or not, whether they have diabetic or not. So almost all proteinuria, to reduce proteinuria, these 2 drugs are very important. The newer drug is SGLT2 receptor antagonist. That is an anti-diabetic newer group of drug. sodium glucose transporter 2 receptor antagonist. This is also a very good drug. Basically, it was used as a drug in diabetes. They found the proteinuria is less, so they said you can use it as something which can prevent nephropathy, use it in the early stages. Then they started using even in a non-diabetic individual with proteinuria. So somebody with ACE still not having full benefit, they started using SGLT2 receptor antagonist, and they found a fairly good result. A drug which is on a lot of things, which another 5-10 years it will be in, still the usage will be very much increased in this group of drug, already very much available in the market. So renin-angiotensin system, we know it is the one. Renin is produced by the juxtaglomerular apparatus, which convert angiotensinogen 1 to angiotensin 1, which gets converted to by angiotensin 2 by ACE inhibitor, angiotensin enzyme. So by using ACE inhibitor, you block this one, you reduce the production of angiotensin 2, this is, which will in fact act on the vessel, causing vasoconstriction, or it acts on the angiotensin 2 type 2 receptors. I'm sorry, angiotensin 2 receptor, angiotensin 2 type 1 receptor antagonist. So that way it inhibits the aldosterone secretion. By using a ACE inhibitor, similarly as by using ARB, you control the action of angiotensin production as well as the action of angiotensin 2. Thereby, you causes efferent arteriolar dilatation. If you take normal glomerulus, this is the glomerulus which contains this is the capillary, then efferent arteriole. Efferent arteriole, when you use a ACE inhibitor ARB, the efferent arterioles they dilate. So thereby, the glomerular pressure is altered. So thereby, the proteinuria will be reduced. That is what I said as the glomerular hemodynamics. Similarly, you find, so ACE inhibitor ARBs, they reduce the glomerular pressure. So thereby they reduce the proteinuria. Similarly, you find SGLT2 receptor antagonists, they act on the afferent arteriole. That they cause an afferent arteriole, increase afferent tone. Thereby again, it reduces the glomerular pressure. So if like efferent arteriole, ACE inhibitor ARBs are acting, SGLT2 receptor antagonists are acting on the afferent arteriole. Ultimately, they will reduce the glomerular pressure. Thereby, they reduces the proteinuria and so on. So the proteinuria is reduced by these two drugs, which are specifically acting at the level of glomerulus, and they are very useful for the glomerular proteinuria. So any questions or anything you want to clarify? Is there any question? Okay, shall we close it?
Sir, I think no doubt, sir.
Okay. Okay,
Thank you, sir.
Thanks a lot, sir.
Right. Bye.
Thank you, sir.
Rahul, we can end the meet, no? ഇവൻ ഇറങ്ങിപ്പോയി തോന്നുന്നു. അല്ല ഹോസ്റ്റ് മീറ്റ് എൻഡ് ചെയ്യുന്നില്ല. അറിയില്ല തോന്നുന്നു സാർ പോയിട്ട്. രാഹുൽ hello Rahul, we can end the meet.